Welcome to Suicide Awareness. I'm Denise Miller, and I'm with the Canadian Mental Health Association of New Brunswick. I've been on board for almost 14 years and absolutely love my job. I get up every morning and say that I get to go to work. I don't have to go to work, I get to go to work. So there's a difference. And Dustin is just new. He's, I think, our newest employee. So it's so nice to have him on board, and he brings a lot of experience and knowledge that is so useful to us, the staff, and just to be able to share and our knowledge and everything is always fun. So anyway, so Dustin and I are going to take you through this tonight. We'll work our way through this presentation. All right. So suicide awareness, we often think of helping someone who may be at risk of suicide as an extraordinary act, or that it requires some specific professional credentials or experience. While some people are mental health professionals, a large majority of individuals are caring friends, family members, co-workers, classmates, peers, teammates, community members, acquaintances, and some of them are even strangers. So we don't need to be professionals to equip ourselves with some basic information, which can give us the tools to help somebody else in need. So a little bit of background history on the Canadian Mental Health Association. Nationally, we are a not-for-profit, we are a charitable organization, and we've been around for over 100 years. That's amazing. For any not-for-profit to be around over 100 years is phenomenal. And in that time, we have seen a lot of change and a lot of growth, but probably in this province anyway, not as much as we have in the last 2 years, where we as staff went out into the communities and met with people and did groups in person and all that kind of stuff. Over the past 2 years, because of COVID, we've pulled that back and we've gone online with everything. So we've had to do a lot of learning as staff, how to get online, how to work Zoom, how to do presentations online, how to reach our, our participants and everything else. But it's been a super, super positive experience. I mean, we went from serving 87,000 people a year up to last year, 204,000. We almost tripled the amount of people that we served in the province. So it's been amazing. And I think for stigma, it's allowed people to still continue to learn and get the information and not feel threatened. They don't have to put their cameras on. They can change their name, all that kind of stuff. So they can still be anonymous and still get that information where you couldn't really do that in person, right? So as a province-wide leader and champion for mental health, CMHA in this province helps people access the community resources that they need to build their resilience and to support them in recovery from mental illness. So what do we look like in this province? Well, we have 18 locations provincially, so it doesn't matter where you are in the province, we've got you covered. So our 3 main offices, our provincial one is Fredericton, and then we also have offices in Moncton and St. John. Those offices have typically 2 or more staff in them, where the other 15 offices pretty well have 1 staff person in it. So like myself, I cover Westmoreland and Albert counties. So I travel from Port Elgin to Sackville to Dorchester to Memramcook, Salisbury, Petitcodiac, Hillsborough, Riverside, Albert, Alma, and Elgin. I do all that region. Dustin is up on doing the Woodstock area, right, Dustin?
Yep.
Yeah.
Sure am. So I go Harvey, Nakawick, Woodstock, up to Plaster Rock and Perth Andover.
Right. So there you go. So you can see how, each of us are covering, and we have these zones. So it doesn't matter where you are in the province. If you're looking for resources, information, programming, whatever, please, for heaven's sakes, reach out to us. Our website, Dustin, maybe you can type in the website for CMHA, but all our contact information, everything is there, and we'd be absolutely thrilled to be able to help you out in whatever way you're looking. Now, we also have a community program coordinator program, of which Dustin and I are part of. We're CPCs in the province. And that's what we do. That's our role. We go out into the rural areas of the province. So everywhere that Fredericton, Moncton, and St. John offices don't cover, we cover. So we're good. We take the office on the road and we head out into the communities. We also have a provincial peer support program. They work with people with lived experience with mental illness, and is to instill hope and inspire others going through similar circumstances that recovery is possible. So they have access to grant funding to maybe help people that need to get equipment to start work. Maybe they need work boots and a hard hat, that kind of stuff. Well, they have access to funding that can help them get that. Maybe it's to help people apply for grants and that kind of thing to go back to school, to either go to community college or university and further their education. Maybe it's to help them write resumes and go through possible questions like an interview questions and that kind of thing. So they're there to support. That program currently exists in Charlotte County area, which is down by St. Andrews, St. George, that kind of area. But hopefully someday we'll have enough funding that we can actually take it province-wide. We also have an employment, okay, I got that all confused. Excuse me. I started talking about provincial peer and then I jumped onto the employment program because my eyes are actually looking at employment program line. So that Working Stronger Together program, that's what's down in Charlotte County. The provincial peer support program, that's tied in with our FACT teams. There is a provincial peer support person on each team, and they're there to walk the walk and talk the talk with those living with mental illness that qualify through FACT to have that peer support. And it really is somebody who's been through the system and can understand how to navigate, understands a little bit of the resources in the community, and is kind of there to say, you know what, I'm and I am living with depression and anxiety. So I'll often share with people, I understand what it is you're going through. So it's like a peer relationship, right? When you can support that other person. And then we have an amazing program called Bounce Back. Our Bounce Back program is free guided self-help program grounded in cognitive behavioral therapy, which is CBT, to help adults 19 and up learn skills to better manage their depression and anxiety. And as I mentioned, I do live with depression and anxiety. And when we got our first Bounce Back coaches trained, I decided to enroll in the program. At that time, we didn't have any wait lists or anything like that. They were just starting to pick up new participants. So I applied and I decided that I wanted to try this as a participant to see what else I could learn. Because of what I do for a living, I know a fair amount. I don't know it all by no means. And I learn, I'm still learning every day, 14 years later. But I thought maybe I can learn some tips and strategies, and by the jumpins did I ever learn. It's an amazing program. It's done through telephone coaching. So the coach reaches out, touches base with you. They send you a couple of booklets. The booklets are really nice. They're 8.5 by 11, and there's several pages. And you sit down and you work through that booklet on your own. And then 3 weeks later, your coach calls you and you have discussion on those 2 booklets. So you talk about what you've learned, the exercises that you did, any struggles or things that you were confused about or challenged with. That coach is there to work through that with you and to provide that support. An amazing program. And I did learn a lot of strategies. So I was very thankful that I was able to utilize the program. It does require you to have a medical practitioner. And the reason is if you're struggling a lot through the program, that Bounce Back coach can reach out to your medical practitioner and suggest maybe to have a meet with you. And just to kind of have that check-in and make sure that all is good. But what's really nice is my doctor received a really nice package from my coach when I first signed up that gave her all the understanding of the program that I was about to go through. So my doctor could see what it was that I'd be learning and how it would benefit me. And she could support me on my visits to her. She could support me in that effort. So it really, really was a great, it's a great program. They're usually pretty quick to answer back. And they have coaching available in English and French. We are actually in the process of hiring a couple new bounce back coaches because the program is growing. So there may be a wait list, but hopefully we'll be there for long with a couple new staff coming on board. So if you're dealing with depression or anxiety, it's really worth looking into. And again, you'll find that right on our website. I'm going to put up a couple of comments here, and we're going to see if what you think, if they're myth or if they're actual fact. Talking about suicide may give someone the idea of suicide or push them towards thoughts of suicide. Is that true or false? False. You're right, Rena. You're absolutely right. Asking people if they are thinking about suicide does not give them the idea for suicide. And it is important to talk about suicide with people who are suicidal, because you'll learn more about their mindset and their intentions. And it allows them to diffuse some of their tension that's causing them to have suicidal feelings, right? So by asking about it shows that you care enough and that you're perhaps comfortable enough to have some discussion on it. So it's very, very important. There's a lot of positive that comes out of asking about it. And it just means, and if they're not, they'll say, gosh, no, is that the feeling that you're getting, that's where I'm at? Well, I've been concerned. I've been worried. And then it opens up that door for that conversation, and you're able to provide that kind of support. It's not going to insult anybody, I can assure you. When my depression got really, really bad, and I got up one day and I did have thoughts of suicide, if somebody would have reached out to me, and my doctor did when I called her up and said, I need to see you now, she made time for me that day and I went down to see her and she asked me, and we had really good conversation. So by the time that I was ready to leave, she was more comfortable that I'd be fine. But for me, a lot of it was just to release what was built up, just to get that out. So that was very helpful. So the next one, people who talk about suicide should not be taken seriously. True or false?
Rena says false again.
Absolutely. People who are talking about or expressing thoughts of suicide should be taken seriously. Oftentimes, it can be a way of looking for help when they're not knowing where to turn. So even if they don't really mean it, maybe it's their way of asking for help. If I tell you that I'm struggling and I tell you that I'm hurting and that I can't take this anymore and I'm pretty well at the end, will you listen, right? So yeah, I think if somebody actually does talk like that, you need to listen and you need to ask the question. And the next one, people who talk about or attempt suicide are just looking for attention. Is that true or false? False.
False.
Yeah. People who die by suicide usually talk about it first. They're in pain and oftentimes they reach out for help because they don't know what to do and they've lost hope. So always take the talk about suicide seriously, always. So you were bang on again, Rena. Absolutely true that it's false. Absolutely true that it's false. You were correct that it is false. And that's what happens. You know, people are not just looking for attention. It's not something you just bring up for the heck of it or lack of something else to talk about, right? So it's really important. And then once someone has attempted suicide, they will not try again. Is that true or false? False again, Rena. That's right. Once somebody has attempted, yeah, people who attempt suicide and survive will oftentimes make additional attempts. So it's really, really important. If you're suspecting, if you're wondering, if you're thinking, please take the time to ask, because it can always be better than not having asked, right? So more myth or fact. A suicidal person clearly wants to die. True or false? That's right, false. The vast majority of people who are suicidal do not want to die, but they're in such pain and they want to stop the pain. Okay, so that's what's happening. Someone who is smart and successful would never die by suicide. True or false? False.
Correct.
Right? Suicide can strike anyone. It doesn't matter what demographic a person may represent. Anyone is at risk of suicide. And that falls true for mental illness in general. Mental illness knows no religion, it doesn't know sex, it doesn't know age, it doesn't recognize any of those things. Anybody and everybody is susceptible to developing mental illness. I mean, look at how much knowledge I would have gotten over the past 14 years about mental health and mental illness. Yet I still developed depression and anxiety a couple of years ago. Now, my depression got bad 2 years ago. My anxiety had been there for years and years. I just thought that was normal. Boys, do I ever know different now? I know real different now. So, but which is a good thing. Suicide generally happens without warning signs.
False.
Right. Things are there's almost always warning signs. And we'll look at those in a bit, but there's almost always warning signs. Suicide rates are higher at Christmas time. True or false?
That is a tricky one.
Not sure. That's a good answer. There is a time of year when suicides are more common, okay, says Dr. Valenstein, a research scientist at the Department of Veteran Affairs and Health Services Research and Development Services. But she said it's not when everybody thinks. Most people think the winter holidays are a risky time, but suicides are lowest in December and peak in the spring. So there you go. There's a piece of information. And males have the highest rate of suicide in North America. Women attempt suicide more often than men. However, men die by suicide more often than women. 80% of those lost to suicide are men. And that's exactly what it is, Rena. It's because they use a more lethal weapon, that kind of idea, more lethal means when they are dying. So for an example, a woman may take an overdose of medication, but she may be able to save herself or somebody save her before the medication has actually done what it was supposed to do. Where with men, it would be a different story. They would have a more lethal type of method. So yeah, so great answers, Rena. I'm impressed, very impressed. So, all right, so suicide in Canada. Let's look at some stats. There were 4,157 deaths by suicide in Canada. That's the 2017 statistics. 3,112 were male and 1,045 were female. So according to the New Brunswick Health Council Population Health Snapshot for 2014-2015, suicide is ranked as the third cause of avoidable deaths in New Brunswick. And suicide accounts for 24% of all deaths among 15 to 24-year-olds. 1 out of every 4 deaths in that age group are as a result of suicide. In New Brunswick, there have been up to 100 suicides reported annually. This number may very well be underreported. And the reason why we say that is it has to be a confirmed suicide. So they left a note or they told somebody they were going to do that. It's confirmed. But somebody losing control in the middle of the night on a road and dying in an accident, that becomes ruled an accident. Was it an accident? We're not sure. If they didn't leave a note, if they didn't tell anybody, it has to be ruled an accident. So that's where that comes in. So the World Health Organization reports that there is 1 suicide every 60 seconds in the world. Somebody dies by suicide every minute. That's really sad. Really, really sad. Okay. So what is suicide? Suicide means that someone ends their life on purpose. However, people who die by suicide or attempt suicide may not really want to end their life. Suicide may seem like the only way to deal with difficult feelings or situations. Okay. So, whatever they're going through at the time, they've tried everything they can to figure out how to make it work and how to bring an end result to it. And they aren't able to. So, that's what happens. So, who's at risk? Well, let's take a look. People who suffer or who have suffered from abuse, neglect, or who are socially isolated. People who have been or are in trouble with the law. People who are struggling with their sexual identity. People with serious mental or physical illness. People who have attempted suicide in the past or know someone who has. People who have experienced a recent loss or a major life change. So in other words, anyone can be at risk because we can all relate to those. We can all relate to those statements. And we understand where this is coming from. You know, about 4,000 Canadians die by suicide every year. Suicide is the second most common cause of death among young people, but men in their 40s and 50s have the highest rate of suicide, while women are likely to 4 times more likely to attempt suicide than men. Men are 3 times more likely to die by suicide than women. We looked at that statistic. Suicide is a complicated issue. People who die by suicide or attempt suicide usually are feeling overwhelmed, hopeless, helpless, desperate, and alone. In some rare cases, people who experience psychosis, losing touch with reality, may hear voices that tell them to end their life. Overall, anyone can be at risk of suicide. Some of those circumstances that may involve increased risk include, but are not limited to, individuals living with poor mental health and mental illness like depression and bipolar schizophrenia. And then again, here we go, right back over that list again. You know, people with physical illnesses like cancer or are paralyzed, where they feel they're a burden and it's going to put too much on their families, right? And their friends, they don't want to burden them with that. Those kinds of things. These are the people that are at risk. So suicide, how to help. So we want to look at being able to be a support and being a connection. So if you're concerned that someone you know may be thinking of suicide, you can help. Remember that as a helper, do not promise to do anything that you don't want to do or that you can't do. First of all, if the person is actively suicidal, get help immediately. Call your local crisis service or the police, 911, or take the person to the emergency room of your local hospital. Do not leave that person alone. If the person has attempted suicide and needs medical attention, call 911 or your local emergency service numbers. Very important. So how do we help and support someone who may be at risk of suicide? Well, it's not fixing everything, and it's not making everything okay, and it's not counseling. But it is supporting, caring, providing connections to professional help, and calling in emergency resources when necessary. We should never think at any point that we are counselors unless we are certified counselors. We want to do what's best. We want to be able to help. We want to be able to, keep that person safe and everything else. But we don't have the counseling knowledge. Perhaps that would be really helpful. But what we can do is support, right? I hear you. I'm listening to you. I think we need to call for help. So let's get some help. You're letting them know you care. You're wanting to provide that connection for them to professional help. So maybe they say, look, I can't call anybody. Say, I'll call. I'll make the call and I'll hand you the phone. So I'll reach out to mental health services and I'll call the clinic, and then you take the phone and you set up that you want to have an assessment with them and everything else, because they'll need to talk to you. So we'll do this together, right? That's supporting, that's caring, that's helping provide that connection to that professional help. And then if it's beyond that, it's calling emergency resources when necessary. Or if you're feeling completely uncomfortable and unable to be that support caring person that that person needs at that moment, reach out for help. Call a family member, call 911, do what you need to do to get support to that person. That's extremely important. That's what they're really needing at that time. So how do we help? Well, here's an easy way to remember the steps when you're trying to help someone who may be at risk of suicide. We're going to review each of these more specifically. So, sell. That's really kind of a cute word. We're going to sell ourselves on this, right? S, we're going to spot signs and symptoms. We're going to observe the person. And we're going to verify what we gather, right? We want to explore. We want to share your concerns and ask directly and clearly about suicide, and establish that connection with them to reach out and show that you care. Let that person speak without interruptions. So you want to listen. Show respect and do your best to be non-judgmental, and determine the risk. Do I need to get help here right now? Or can this wait till tomorrow morning? What is the risk here? So that's when then I may link them with resources. So we want to spot signs and symptoms. We want to explore with them, like, wow, this is not their usual behavior. It's been different because I've noticed these different signs. So maybe I need to ask about it and listen. I took a course on communication once, and the gentleman said it's very important as carers and supporters that we learn to listen to understand rather than listen to respond. He said, when we listen to respond, somebody that we're in communication with has said something that triggered a memory, and now we're focused on them stopping to catch their breath so you can interject and share that memory and go, oh yeah, I went through a similar thing, and then share your story. So from the moment they said that until they stopped to catch their breath, you ceased listening to them because you were focused on wanting to say your part. But if we listen to understand, we're simply sitting and listening. We're hearing what they're saying. And sometimes that's all the validation that a person needs, is simply to feel like they've been heard. Oh my gosh, she's really listening to me. So then when I turn around and say, you know what, I care, and I want to help you get your way through this, I'm going to sound sincere to that person. They're going to feel that I'm sincere by having reached out and by listening, right? So listening is so important. We want to make sure that we keep doing that. So I'm just flipping through my notes here. Just want to make sure I don't forget anything. All right, so warning signs of suicide. Well, general warning signs of suicide can come in many different forms: behavioral, physical, life circumstances, feelings and thoughts, and verbal. We're going to look at those in more detail. Warning signs are important to recognize. They are shown through changes in our life circumstances, our thoughts, our feelings, our physical changes and behaviors. All of these are connected with each other. So paying attention to changes in a person related to these areas is important because they are symptoms that something is wrong. Just like coughing, fever, sweats, and a sore throat are symptoms to a flu, the same can be said about changes to our thoughts, feelings, behavior, and body act as the warning signs to possible suicide. So warning signs. Well, let's, take a look at where things are at. So before signs and symptoms present themselves related to the risk of suicide, individuals may also experience other types of concerns, including depression, gambling, alcoholism, and substance abuse related concerns, of which, with early recognition, prevention, or intervention, may also support the prevention of suicide. So we will now look at warning signs of each of these before moving into the warning signs of suicide. So much like the weather is both stable and always shifting, so too are our emotions. As such, there are times that we can feel low, feel blues, or we can just feel down sometimes, or feel grief over loss or crisis or disappointment. But similarly, we may get anxious before a high pressure event, a move, or entering any setting that makes us feel insecure or self-conscious. We may worry about our health and the well-being of our friends, family members, about paying off our bills. If we never felt sad or anxious or worried in our lives, we wouldn't be human. So, depression, also known as clinical or major depression, is a mental illness that will affect 1 in 8 Canadians at some point in their lives. It changes the way people feel, leaving them with mental and physical symptoms for long periods of time. It can look quite different from person to person. Depression can be triggered by a life event, such as the loss of a job, the end of a relationship, or the loss of a loved one, or other life stresses, like a major deadline, moving away, or having a baby. Sometimes it seems not to be triggered by anything at all. Depression has also been found to be the leading cause of suicide. So while depression can affect anyone at any time, it doesn't seem to emerge most often when a person is going through changes, or it does seem rather. Changes can be negative life changes, such as the loss of a loved one or a job. Physical changes, such as hormonal changes or the onset of an illness. Because depression can be linked to change, certain groups of people are at risk more often than others. For an example, youth. More than 250,000 Canadian youth, 6.5% of people between 15 and 24 years of age, experience major depression each year. Depression can be hard to recognize in youth because parents and caregivers often mistake a teen's mood swings and irritability for normal adolescence rather than depression. Studies have shown that gay, lesbian, bisexual, or transgendered youth have higher rates of major depression. Older adults, around 7% of seniors have some symptoms of depression. This can be brought on by loss of a spouse, a shrinking circle of friends, the onset of an illness. It's also much more common among seniors living in care homes or who have dementia. Depression in people 65 and over appears to be less common than in younger groups. But researchers aren't sure if this is a real difference or an issue with the research questions. It's likely that depression is at least somewhat under-recognized in seniors. Some symptoms, like changes in sleep or activity levels, may be mistaken as signs of aging instead of depression. Women, depression is diagnosed twice as much in women as it is in men. Some reasons for this difference include life cycle changes, hormonal changes, higher rates of childhood abuse or relationship violence, and social pressures. Women are usually more comfortable seeking help for their problems than men, which likely means that depression in men may be highly underreported. Men generally feel emotionally numb or angry when they are depressed. When they're depressed, whereas women usually feel more emotional. Okay, so men, it's more the physical signs, women, it's more the emotional, mental signs. So people with chronic illnesses, about 1/3 of people with a prolonged physical illness like diabetes, heart disease, or mental illness other than depression experience depression. This can be because a long-term illness can lower your quality of life, leading to depression. People with substance use problems. There is a direct link between depression and the problem substance use. Many who are experiencing depression turn to drugs or alcohol for comfort. Overuse of these substances can actually add to depression in some people. This is because some substances like alcohol, heroin, and prescription sleeping pills lower the brain activity. They are depressants. They make you feel more depressed. So even drugs that stimulate your brain, like cocaine and speed, can make you more depressed after those effects wear off. So other factors like family history, trauma, other life circumstances may make a person vulnerable to both alcohol and or drug problems and depression. And then people from different cultures. Depending on your cultural background, you may have certain beliefs about depression that can affect the way that you deal with it. For example, people with some cultures notice more of the physical symptoms of depression and only think of the emotional ones when a professional asks them. Attitudes from our cultures can also affect who we may ask for help. So, what are the depression symptoms? What to look for? Feelings of worthlessness, hopelessness, and helplessness. And those three I did experience. When my depression reached its peak, I really felt worthless, hopeless, and helpless. Sleeping more or less than usual, eating more or less than usual, difficulty concentrating or making decisions, a loss of interest in activities that are usually enjoyed, a decreased interest or a desire in sex, avoidance of other people, isolating oneself, overwhelming feelings of sadness or grief, feelings unreasonably guilty, just feeling guilty for everything, lots of unexplained stomach aches and headaches. There used to be a commercial on TV called depression.ca, depressionhurts.ca, and they would show people dealing with physical symptoms of depression. I can assure you that is accurate. When my depression got bad, I was feeling physical effects of the depression because there were no plausible reasons or explanations as to why I had headaches, stomach aches, all of that, other than the depression. Feeling very tired or restless, thoughts of death or suicide, feeling more tearful or irritable than usual, and engaging in problematic substance use or gambling to try to cope, as a means to cope. These signs are outside that person's norm, okay? So just because a person likes going to a casino and they go once every 2 or 3 weeks or once a month, and they go with a limited amount of money and they go just to have a night out and some fun with friends, that does not mean they're suffering of depression. It's all of a sudden when they're using their last bottom dollar and they're at the casino all the time and they're using that. And then you're seeing perhaps some other signs too. When my depression was at its peak, I didn't feel every one of those signs. I didn't have every one of those symptoms. I had a lot of them, but I didn't have them all. So depression is as unique to each person as we are each unique to each other. So in other words, I might have had 8 or 9 of those symptoms. And if Dustin had depression, he might have 4 or 5, and they wouldn't be the same ones that I had. So we need to understand that because we're unique and we're going through different situations and life events, and we've gone through different situations and life events where we've learned coping strategies in the past. So maybe we're dealing with symptoms differently. I'm more able to cope with the sleeping and the eating, where my feelings of worthlessness, hopelessness, and helplessness were exacerbated. They were really, really bad. But Dustin could be dealing with the sleeping issues because he hasn't learned how to cope through those and work his way through that. So it's always different, right, to each person. But as long as we're comfortable with recognizing some of the signs, and it really is obvious, like it can be quite obvious if you're looking for them. if you're looking for them, so if you have a friend or a family member that has been going through some really, really difficult times, start looking for those symptoms. Start paying attention to their behavior and their thoughts, all of that kind of stuff, their mental, emotional feelings, their physical feelings, and their behavior. You might see some warning signs right there. So substance use concerns. We all use substances, and many of which affect our mood. Whether we eat something that gives us pleasure, such as chocolate, or enjoy a glass of wine to enhance a meal, or take prescribed medication to control pain from a recent injury. The use of substances is an accepted part of life. Many people can use substances in moderation without experiencing problems. What we need to remember is that all substances have effects. Some have greater risks. So potential problems with substances are binge drinking on the weekend, overuse of prescription drugs, consuming club drugs at a rave, drinking more than 5 cups of coffee, smoking caffeine, or rather cocaine, are all examples of potentially problematic forms of substance use. So usually when problems arise from this use, there's a range of other factors at work. And when depression or anxiety are in the mix, substance use may be a sign of self-medicating. Self-medicating is using substances to attempt to dull, numb, or distract oneself from negative symptoms, pain, and stress. So through substances like alcohol and other drugs, a person may be seeking just to simply alleviate in a sense of anxiety or depression, powerlessness, pain, or boredom that may pervade their life. They may also be using the substances to try and relieve physical symptoms or side effects of medications. So what happens is inappropriate use of some prescription medications to address depression or anxiety can lead to problems. Some medications can result in physical and mental dependency, and withdrawal can be very difficult. The interactions between anxiety and depression and substance use are complex. While substance use or may be used as coping mechanisms by people with mental health problems, the substance use can also worsen or trigger anxiety or depression. For example, alcohol may temporarily relieve feelings of anxiety. However, the long-term alcohol misuse and acute alcohol withdrawal can often increase anxiety levels. And in all honesty, if we look at people turning to substances to help them cope, they're actually creating another problem for themselves, because it doesn't solve our problems, but it creates a new problem, right? It creates us abusing and using and becoming dependent. So what to look for? The substance use concerns: drinking or use in response to stress, stomach pain, drinking or use more than intended, spending more money than in the past, especially on alcohol and drugs, and especially more than what someone may be able to afford to spend. Secrecy or attempts to hide their whereabouts, substance use or drinking from others. Previous attempts to manage or reduce substance use or drinking have not been successful or effective. Missing school, work, or a drop in their performance. Caring less about school, work, or other responsibilities. In other words, reduced motivation, right? They don't care anymore. Changes in their sleeping habits, eating habits, or behavioral patterns. Reduced concentration and memory. A loss of interest in appearance or their hygiene. So they're not kept up anymore. They don't take the time to brush their hair. They maybe haven't changed their clothes in 2-3 days. They haven't had a shower, and you can tell they haven't had a shower in a few days. Those kinds of things. Mood changes and personality changes, confrontational behavior or rule breaking. They're going to push the limits. Association with a new group of friends or acquaintances not connected to other social groups. So it's being aware of all these different things, right? So depression, anxiety, and substance use what to look for, feeling tired most of the time, or having little energy left to get through the day, trouble concentrating and remembering things or making decisions, feelings of helplessness, change in sleep patterns, sleeping a lot or having trouble falling and staying asleep, frequent feelings of irritability, agitation, anger, or being argumentative, and the symptoms interfere with daily activities or routines. So, gambling signs. Behavioral, stops doing things he or she previously enjoyed, misses family events, changes patterns of sleep, eating, or sex, ignores self-care, work, school, or family tasks, has conflicts with other people over money, uses alcohol and other drugs more often, leaves children alone, and seems less concerned about who looks after them. They neglect their basic care, thinks about gambling all the time, is less willing to spend money on things, other things than gambling, cheats or steals to get money to gamble or pay debts, has legal problems related to gambling, is often late for work or school, organizes staff pools, another form of gambling, and is gone for long, unexplained periods of time. Emotionally, they withdraw from family and friends. They seem far away or anxious, and they have difficulty paying attention, mood swings, outbursts of anger, complain of boredom and restlessness, and they seem depressed or suicidal. Their health complains of stress, related health problems such as headaches, stomach aches, bowel problems, difficulty sleeping, overeating, or loss of appetite. Financially, frequently borrows money or asks for salary advances, takes a second job without a change in finances, cashes in savings accounts, RRSPs, or insurance plans, alternates between being broke and flashing money, has family members who complain that valuables and appliances are disappearing or that money is missing from a bank account or a wallet. So, how to spot signs and symptoms. Actions and behaviors, previous attempts of suicide, withdrawal, social isolation, risk-taking behavior, substance use, misuse, discussing the topic of suicide, giving away valuable or meaningful possessions, a decrease in personal care. Verbally, they're discussing the subject of death, expressions of hopelessness, helplessness, guilt, and worry. They're verbalizing giving up. Nothing will ever work out. They're very, very pessimistic and negative. Also, another thing too that's important to mention is when all of a sudden they've been experiencing a lot of these signs and symptoms, and then all of a sudden the next day they show up and they're happy and they're calm and they're relaxed. Be very aware. A lot of times that will happen once they've made a decision to do it. They've made the decision, they've developed their plan, they know exactly how, when, where, and by what means, and they're comfortable with their decision. So if you were really wondering if you should ask, please take the time to ask them. Because it doesn't mean, oh, they've just gotten over whatever they've been going through for the last 6-7 months. No, it means something, it has the potential of meaning something a lot more serious than that. So feelings of sadness, desperation, worthlessness, loneliness, isolation. And loneliness and isolation, I did a presentation recently on challenging loneliness and isolation. And I made a point of saying in there, I can be in a room full of people and be lonely, but I can be by myself and feel alone and be alone. It's a lot of it is the mindset. And it's really understanding that, yes, we have been isolated for the past couple of years. We've gone through a lot, but it's to be comfortable in the time that you're being alone, rather than focusing on all the things that you have to live without, that you can't have around you, that you can't have within your life, and feeling the sense of loneliness. Focus on the positive of that. So it's really a mindset. Guilt, anger, frustration, distress, worried. the sudden boost in mood. That's where I was talking about. That's where you really need to pay attention to that. And then, of course, life experience has been exposed to and survived abuse. And then so many different kinds of losses that one can experience. And that always, always has a dramatic effect. So to remember the warning signs: is path warm? Ideation, somebody is thinking about it. Substance use, they're having problems with drugs and or alcohol. The purposelessness is feeling that there is no purpose in life or reason for living. The anxiety, feeling intense anxiety or overwhelmed and unable to cope. Trapped, feeling trapped and that there's no way out of this situation other than this. This is it. Hope or helplessness, no hope for the future. Things will never get better. Withdrawal, avoiding family, friends, and activities. Anger, feeling unreasonably angry. Recklessness, engaging in risky, harmful activities that they normally would avoid. Speeding down the road when they normally wouldn't speed. All of a sudden, they're driving 30, 40, 50 kilometers over the speed limit. So, and then, of course, the last one, mood changes, a significant change in mood. So we want to explore, we want to ask those questions, we want to, really ask them about their thoughts and their feelings. Where are you guys at? What is it that's going on in your head? What are you feeling? And then we can ask them questions, make them clear. Are you having thoughts of suicide? Are you struggling really hard right now? Can I help? Can I listen? Ask the questions that are direct. Ask questions about suicide. Asking questions about suicide is helpful if you believe that person is at risk. I'm asking you if you're having thoughts of suicide. If you are, can you please share with me what your thoughts are? Do you have a plan? Do you have a method? You're going to use medication. Do you have that medication with you now? Can I have that medication, please? So we want to make sure we're asking those appropriate questions. So again, it's crucial to be prepared to listen. Be aware of the verbal cues, right? The vocabulary that they use. Minimizing things. Oh, it's not that bad. And we want to make sure that we're not doing that. It's not as bad as you think. And don't worry about it. You'll get over this. And, suck it up. And no, in cheerleading, no problems. I'm on your side and I'm going to cheer you over that goal line. And we're going to beat this. We've got this. And being judgmental, why would you want to do that? That's so selfish of you. And think about your wife and your children. And those are my judgments. There's no place for my judgments, my opinions in this. That's not what that person needs to hear. Giving advice, again, that's not our place. We don't need to play the therapist unless we really are a certified therapist. We just need to listen, right? Promising that things will be okay. We can't make that promise because we don't know for sure that they will be. And problem solving. Well, we can maybe help them with the problem solving. Absolutely. I can't tell you everything's going to be okay, but gosh, let's take these problems one at a time and see what we can work through and how we can get somewhere from here. Let's see what resources are available to you. Link the person to further help. Help comes in many forms. Okay, so make connections for them. Community resources, support networks, emergency services when necessary. If you believe they're at risk, don't leave them alone. If you can't stay with them for one reason or another, reach out to somebody who can come stay with them until help can arrive. If you're unsure what to do, get help. Okay, so link the person to further help. Help comes in many forms. Respond honestly. Don't make promises that you don't know if you can keep. And just be honest. They don't expect you to have all the answers. They hope that you'll listen. So let them know that you care. If you're unsure what to do, reach out for help. When in crisis, it can be difficult to problem solve. And having a crisis action plan in advance can help for those who you already know can be at risk. So that part of it's really important. There's a couple of questions here. We're a small group of people and time is almost up. I'm just going to briefly just review them. So what keeps us from responding to people's personal pain or someone who might be struggling? I think probably the biggest reason is fear, right? Fear that we may say something wrong, we may do something wrong, we may not have the know-how on how to fix their problem. Remember, we're not there to fix their problem. We're there to support and to care and to listen and reach out for help. So what are common things that we all do to avoid responding to someone's personal pain? We maybe talk about our own, right? Or we'll change the subject because it's not as uncomfortable. We don't want to feel uncomfortable. Oh my God, if she opens up and really starts to tell me how she feels, how am I going to handle that? How am I going to deal with that? I've got a lot of stuff of my own going on. I don't know if I can deal with that. So those are the kinds of things that we can be thinking and experiencing. So gatekeeper is basically that person who is really looking at trying to be that supporter, that carer. So the gatekeeper recognizes warning signs. It's like, wow, now that I know what the warning signs are to look for, I'm really picking up on 6 or 7 of those in that friend of mine, So maybe I need to ask more questions. I'm going to need to gather more information. So I'm going to have a conversation with him. And I'm going to ask him if he's having thoughts of suicide. I'm going to ask him, and if he says yes, what is your right? So here you go. Gather information, the presence of suicidal ideation. If he says yes, then I want to verify for the urgency of the situation, how, when, and where. Do you have your plan developed? And then provide information to identify clinical resources to determine the next steps. So if it's something he's planning on doing in the very near future, I'm going to reach out to 911 and I'm going to get him some help right away. Let's get him to the hospital. Let's get him to emerge where he can be evaluated and we can get him some help. But then if it's a no, then inform the person on available services and encourage them to keep seeking help. No, I'm not having thoughts of suicide, but I'm really, really struggling. Okay, well, what are you struggling with? Maybe I know of resources that can help you and I can help point you in that direction. So hopefully ever having to avoid going down the walk or the road of having suicidal ideation. So that's what we're trying to do. We're trying to avoid having to let a person get there. So if you're having thoughts of suicide, call a crisis or a support helpline. There are a few. Draw on the support of family and friends. Talk to your family or family doctor. He or she can refer you to services in the community, including counseling and hospital services. Set up frequent appointments with a mental health professional and request telephone support between appointments. That's possible. Get involved in self-help groups. You have to make effort too to get better. Everybody can't make the quick fix for you. You're having to be prepared to put the work in and the energy to get healthy, to get better. And the more that you succeed at it, the more it inspires you and motivates you to do more. Talk every day to at least one person that you trust about how you're feeling. Think about looking for help from the emergency department of a local hospital. Talk to someone who's been there about what it was like and how he or she coped. Avoid making major decisions which you may later regret, right? And that's so important to remember. So in a high-risk situation, never leave the person alone. Get immediate support from parents, police, or hospital emergency. We also have mobile crisis units around the province that are there to help support. Reduce or remove access to the means, but never, ever put yourself at risk. That's extremely important. Never put yourself at risk. So here's an example of the resources that are available in our community. Local mental health professionals and at mental health clinics around the province. I think there's 7 of them, if I'm correct. Peer support consultants, mental health mobile crisis units. You'll find all these numbers in the blue pages of the phone book. Well, phone book, listen to me, how old I am. You can go online. You can all go online And you can just Google these and they'll come right up with phone numbers. Local mental health and addiction centers. There's the CMHA helpline, kids help phone. They have a telephone, a toll-free telephone number, but they also have a text line because a lot of kids today love to text. And of course, family and friends, your 911 emergency, and your local hospital. That brings us to the end of tonight's presentation. Are there any questions, or is there anything that anybody wanted to share? Hopefully everybody's okay. They're in a good place, emotionally and mentally. There you go. I'm just scrolling back, Rena, and I see your comment. Yes, very sorry for your loss. And these are being recorded, not the chat comments, don't worry about that. Just the presentation itself is being recorded. So if you know of somebody that would benefit from understanding, recognizing, and knowing the signs and symptoms, please send them to our website to look under the wellness, I think it's the wellness tab, and then underneath there it says wellness webinars. And if you click on that, it gives you a link right to our YouTube channel, if I did it right. But there's all kinds of information there. And yeah, and there's some amazing websites. The Canadian Association for Suicide Prevention, CASP, they call themselves. There's all kinds of great places where you can get some good information and that kind of stuff. So, and then I did this past week an interview with 3 suicide prevention coordinators in the province. I interviewed them. That was recorded. I asked a series of questions of them. It was done in English and in French. And that will also be available on YouTube. So if anybody's looking for maybe more information or resources, again, you can find those interviews on suicide awareness there. So hopefully it helps. You have our email addresses. If there's any more information you're looking for, or you're looking who the local contact is in your region, you come from somewhere where Dustin and I don't cover, please reach out to us. We'll give you the contact information for that person. Anyway, thank you so much for coming. Hopefully I leave you in a positive state of mind. And you know, already we're way ahead of a lot of other people because we now know the signs and symptoms to watch for. So use those, tuck those away. Those are skills that you have. And if you're ever concerned, put it this way, I was in that position and I would have much rather have somebody ask me and it not be true than not ask me and it was true. So, you know, we're all there for the right reason. We care. So have a nice evening and a great what's left of the week. And hopefully I'll see you again soon. Bye for now.